see Wendy has put in the group. We're pretty lucky that ensure that you have the proper email address that was sent, so that Wendy can ensure that you're going to get some PD points. So let's get started. Our first presenter, we're pretty lucky to have Dr. Shannon Bowman. Dr. Bowman has graduated from McMaster and completed a specialty in family medicine at Queen's and a fellowship in sports exercise medicine at McMaster. She told me not to read all of this. She would like to spend most of her time talking about it, but I think it's very important to understand that Dr. Bowman has extensive research and done a lot for concussions with her program. So just to give a little bit of rundown on that, Dr. Bowman was nominated for Minister's Medal for her innovative concussion care model. She's also an advisor to Parachute Canada, and she'll talk a little bit about Parachute Canada in her presentation. She's also co-authored Canada guidelines on concussion in sport and developed sports-specific protocols for national sports organizations through Parachute Canada. She's been with the Toronto Rock. She has worked with on our national team programs with the women, and we're very lucky to have her tonight.
Thanks, Terry. It's so nice to see all the turnout and some very familiar faces. Thanks, guys. I'm going to share my screen here. Don't have a heart attack when you see how busy this is. And we'll just flip to here. All right. This is just going to be an intro to our night tonight. So I called it Concussion 101. Here's me on the left. This is Dr. Larry Comer. If you guys know Larry, he's been around lacrosse for a really long time. I'm an avid lacrosse fan. I'm a sports med doc. I've had experience as a team physician. I've under some great mentorship under Dr. David Levy. I got brought in with he and Larry Comer to work on the Toronto Rock. Awesome experience, and also did Team Canada Women's Lacrosse. I've co-authored guidelines, as Terry said. I'm a researcher, a policy developer, a clinician, a teacher, and I just love everything to do with sports medicine and concussions. So let's jump to it. What's a concussion? This is just going to stay a really simple level. It's a brain injury. Matter of fact, it affects function. So when we think of a concussion, it's not necessarily structural, but it's the functional side of how the brain behaves, and the injury affects the functions of the brain. Now, it could be a direct force, meaning you do hit your head, or it can be indirect. You could hit your shoulder, you could land on your hip. If there's enough force directed to the brain, a concussion injury can happen. So no loss of consciousness is necessary. Historically, we used to think that, and now we know most do not lose consciousness. And again, recovery is usually within days to weeks. The average recovery time for an adult is about 14 weeks, and for our kids is about 4 weeks. So as we started learning more about concussions, we've actually realized the days that it takes to recover is longer than we once thought. Used to kind of be told it was 7 days, 7 to 10. We know that we're still even seeing changes on some of these functional MRIs, even 60, 90 days past injury. So here's what, this is Chris Giza, a neurologist from UCLA, showing a little video of kind of what happens to the brain when there's a concussion. Again, I'll just watch it one more time. So the area in the brain called the neuron, this is kind of the area where all of the brain functions are happening, these little cells. And when you think about it, we have kind of a cell body that has a cell wall, and then we have messages that are passed through kind of impulses to kind of different areas of the brain that allow different functions. So this is kind of a normal neuron, what it looks like. What we know in concussions is a couple of things. That cell body that looks like a nice cell wall actually becomes stretched with injury, and it becomes leaky. So instead of having this nice contained cell, things such as potassium, which normally is inside the cell, actually goes out of the cell. And when that does, we know it causes kind of a neurometabolic cascade. Basically what that means is potassium goes out through these leaky cells that are damaged from the injury, and it increases the demand for energy. What that means is it's going to take more energy to work those functions of the brain. The other thing that happens is calcium, which is normally outside, is going to leak in. And why that's important is calcium's a vasoconstrictor, meaning it actually restricts blood flow. So at the very time when those cells are needing more energy, needing more blood, needing more electrolytes, what's happening is this injury has calcium that's actually preventing that blood to go to the area where the injury is. So what we call it is basically an energy crisis. We have a need for too much energy and we're not having energy get to where we need at those levels of the cell in the brain where those functions are controlled. So if we think of concussion in a little bit different way, not necessarily your bruising of the brain we used to think. Think of it as a functional injury at these little cells that control the most complex functions of the brain. This is just a quick overview, busy slide, but just shows that cascade I just mentioned, the calcium and the potassium and the need for energy. So what we know is two things. When there's an energy crisis, number one, you don't want to get hit in the head again. So what we need to do is make sure that we're not returning athletes back to play too soon while they're recovering, because we could have some very significant consequences if we get hit again while the brain's still recovering. The second is we don't want to increase that energy demand too soon. So we talked about this being an energy crisis. Things like physical energy, school or work, cognitive energy, even social things that we do. If those functions exceed what the brain can do, symptoms are going to increase. So this is a great opportunity to think about it is if we understand this, we can actually manage concussions and control what we have our individual athletes and students do, making sure that we're not increasing energy demand too soon and making sure that we're guiding them back to help the brain heal and keep them safe as they return. Often concussions is a symptom-based approach. That means what is the individual telling you they have? They may say, I have a headache, I feel dizzy, I'm seeing stars, my vision looks blurry. There's different things, I'm trouble concentrating at school, I feel slow. So these are symptoms. Now, a lot of our historic approach is just based on symptoms. People would tell you the symptoms they had, and the idea was, well, as soon as those symptoms go away, then we return you back. Well, it seems simple enough, but when you manage patients and as an athlete, this is where it gets a little bit more complicated. What I think is if you just have symptoms alone, it becomes concussion is a black box. And what I mean by that is it doesn't give you the answers of, well, how do I treat it? How do I know it's a concussion? How do I know when it's resolved? How do I measure the severity of it? So if you just look at a symptom approach, it doesn't really answer those questions. And I call those the $1,000,000 questions, both the questions the athlete has and the questions the clinician has. So we need to get beyond just symptoms alone. And a couple different things we need to think about. If we relied on symptoms alone when we return to athletes back to play, we'll realize a few different things. There is not a single athlete that I've ever said, hey, do you want to get back and play? That would say, nope, not today. Athletes will minimize their difficulties that they're having. They want to get back to play. Secondly, there might be some subtle aspects of the injury that the athlete isn't aware of. And just describing symptoms alone might not actually get at those specifics. You're also asking a brain injured patient, do you have symptoms? So do we trust their result? So just relying on subjective information the athlete says, we could actually be underdiagnosing, or we could be sending people back too soon, or possibly keeping people out too long. So we need a really comprehensive understanding of concussion, and we need a multidisciplinary approach. Athletes are part of a team, concussions need a team. We need multiple different ways to assess concussions and different professionals involved to help this athlete return back to school and sport and social. One model that we developed at Concussion North, but I'll just kind of give you a bit of a flow, is see it this way on the left. Athletes come to us different ways. It could be from the field, it could be from the emergency room, an urgent care center, their family physician, a specialist, the sports team they play on, schools. They come into a system. If we look at it this way in the center where we have a physician, a primary care sports med doc, and a team around them that can look at different aspects. They can look at the neck and jaw. They can look at the vision system, the vestibular system, the cognitive, how their brain is thinking, help them return to school or work, help them return to sport. If we need some specialists to work with different things with anxiety and depression and mood changes, or more specialty services like vision that might need other specialist approaches. We can use this team-based care. And then on the right are some other specialists that we might get involved when individuals need other specialists for things we identify during their care. So what does a doctor do in a concussion? And this is a few things that I kind of see the role of a physician. The first is to rule out a significant C-spine, back injury. The second is to rule out a structural form of a traumatic brain injury. This could be a bleed, this could be a tumor, this could be a mass, something that's not concussion, something that's structural. There's other neurologic things and other medical disorders that might mimic the signs of a concussion. This could be someone with a low blood sugar. It could be someone that's having different things like a seizure or loss of consciousness that's not concussion. So there could be other things why we need a physician to examine these patients to diagnose or rule out concussion. We also need to take the symptoms the person's saying, plus, as I mentioned before, look at different clinical features on our exam and really look at a comprehensive approach to the diagnosis and how we're going to use that to guide them back to school and sport and day to day and give them recommendations and follow them all the way through to clearance. So the way I see that approach is they come into the office or you see them on the sideline. You're finding out a more detailed history, their story, what happened, what symptoms they have. Sometimes in some of our teams, we might do some neurocognitive testing. This could be things like impact. There's some other ones on the market, CogSport. Not every team uses this, but it might be part of someone's protocol. A physician would do a detailed focused neuro exam specific to concussion, a medical assessment to rule out a neck and spine injury or other medical conditions. You might have a physiotherapist that's going to work on vestibular, vision, neck, jaw, and other musculoskeletal injuries. We're going to do some testing. It's great if you can have an AT or a PT help to do some physical exertion testing and really oversee those steps. With a team, you're going to have someone involved in helping those aspects from exercise and checking heart rate as they exercise and getting them back to sport specific training. We're going to do assessments of their thinking and their cognitive, their mood, their sleep, how they're doing with activity of daily living and school and work. And then we're going to develop a plan individually for that person. There's no cookie cutter. Each person is unique. Their symptoms they have is unique. So they need a care plan designed specifically for them to get them back to the things that their brain was used to doing at the level it was doing it before the injury. So when I talk about kind of creating these clusters or these features, I used to see concussions as symptoms, but now I see them in groups. So we could have a headache migraine group. We could have that their symptoms are head pressure or sensitive to light. It could be dizziness. I see that dizziness, balance, things under this category. They could have some vision issues, difficulty with reading or remembering what they're reading. Things go in and out of focus. It could be heart rate issues. As soon as they exercise, we see changes where their heart rate starts to not go up with the level of activity, and then they start getting symptoms. They could have difficulty falling asleep or staying asleep or sleeping too much. It could be issues with their neck. Turning their neck is causing dizziness and headache. It could even be their jaw. They get hit, and the jaw, when they clench, is causing symptoms. It could be feeling more emotional. It could be more anxious, more depressed. Cognitive fatigue is feeling slowed down, trouble processing. You feel like you're back a step, not keeping up with the speed of the day to day. I often say the world's in high definition and they're still in standard def TV. We're starting to learn there's other areas, other hormonal areas, other things with glands like the thyroid gland and testosterone, and a lot of work that Larry Comer's done in this area. So what we need to do for each person is to really develop a profile. They could have one of these circles, or they could have multiple circles, and they can work together in kind of a cluster. Once we identify these, it's based on these that we're going to help develop what they can do with school and work and how that's going to affect their care plan. And when we look to clear them, we want to make sure that these clusters we identified from the start have fully cleared and returned back to normal. So these clusters are going to guide our treatment and guide recovery. This is a great model by Chris Giza. I love looking at concussions this way in the recovery. I often say this column to the left, pre-injury. Life is going well, things are great, injury happens. Doesn't matter how the injury happens, but we identify a concussion. First stage is kind of that acute phase. This could be the first days to weeks. We have elevated symptoms. We have these functional impairments. The physiology, like the vision, vestibular, cardiac systems, they're not working the way that they should. They're not functioning. The good news is recovery is starting even there. And we're going to see recovery continue all the way till that full, complete recovery. Somewhere in here is where things can get a bit more complicated. We can either find that some of these systems hit a plateau and they haven't quite made a full recovery. In this, we want to look at those features, those clusters, and really identify that we haven't missed anything. I often describe this to my patient as saying it's a puzzle. If we even miss one piece, that could be the difference of you not getting to this full, complete recovery. Now, the good news is most people go through this and they're better within 2 weeks to 4 weeks. It's really for these ones that get more complex that we really need to dig into this physiologic recovery and work with an interdisciplinary team to make that full recovery. And the brain is still vulnerable. Till we hit that full recovery, we want to make sure that we're not returning people too soon or putting them in contact. So what defines that full recovery? It really is symptom-free with day-to-day activities. They've been able to resume a full school or workday without symptoms being provoked. The physician can do a medical exam and all of the abnormal neurologic or medical exam from the starts return to normal. The vision vestibular systems, if those weren't normal, they're now stable and back to normal. The neck, the jaw, these are stable, and the symptoms that were provoked with this is now recovered. There might be additional neuropsychological tests if they were applicable. Those have been looked at and those are back to normal. The person has been able to go through physical exertion through the point of non-contact practice to be cleared for the next steps, which would be scrimmage and contact play. And this can be done by a physician, nurse practitioner, and it's also going to be done in conjunction with the medical team. This is not done in isolation, but it might be the physician that's required to clear. This is the guideline we produced in 2017 with Parachute Canada. This is called the Canadian Guideline on Concussion in Sport. If you haven't seen this before, Google it. It is free online and it's an amazing resource. This is a whole manual that's going to help develop a protocol for any of your teams. We used funding from FAC, which is Public Health Agency of Canada, through Parachute, got a team of experts together and created this guideline. Then there was additional funding to create sport-specific guidelines for all of our national team sports. All of the resources that anyone would need are included in this, and there's free printables. There's a lot of great things, but this is available. It's now in the process where we're going to be making any revisions based on the Amsterdam consensus that I believe Marcus is going to talk about. So this is going to be updated very soon, but this is just kind of introduction to what this is. It's set up in categories, and I love the flow of it. It has preseason education and resources. So if you're working with a team, there's printables you can use with your teams. There's different head injury recognition cards, ones for parents or non-medical that might be covering, some for pediatrics, and some for medical practitioners that is called the SCAT. We were up to SCAT 5 on this, and now there's a new SCAT that Marcus will talk about. Sideline assessment, it tells you what to do on the sideline. Emergency medical assessments, what might be done. The medical assessment, as I mentioned, the physician role, concussion management, and then multidisciplinary care. It goes through what this might look like, who might provide this, and then there's forms at the end for sports medical clearance you can use. So this is a great resource that's really available for everyone to use. What we wanted was a universal across Canada, so it was harmonized across all the provinces to be used so each sport, each team doesn't have its own, that it follows the same framework. And this was kind of the basis in why we developed this. It has a nice overview of care, a flow sheet for how care is delivered from start to finish. And so this is, again, just something that's going to be updated shortly, and we can always share it when it is. Thank you very much for your time, and I look forward to the next presentation. If there is any quick questions in the chat, depending on time, I'll let Terry moderate that.
Thanks, Dr. Bowman. Greatly appreciated. Gives us a bit of an overview here regards to concussions. And as we've talked, we will build on this education and have further seminars moving forward that will kind of dive into a little more extensively in each category. So, not any questions posted there? Thank you very much, Dr. Bowman. We will move on to Dr. Marcus Robinson next. So Dr. Robinson is a former engineer with Boeing and NASA and a sports medicine physician practicing in Calgary. He's a clinical assistant professor at the University of Calgary. He's the medical director of Innovative Sport Medicine, the medical director of the National Lacrosse League, and the medical committee for World Lacrosse. As a sports medicine physician, he is a team physician for the Calgary Roughnecks, Calgary Hitmen, the Calgary FC, and he's also been with the Team Canada, the men's indoor championships in 2019, U19s in 2022, and the men's lacrosse world championships in 2023, and will be joining us here in 2024 at the World Talks. Marcus grew up playing lacrosse in Victoria before moving on to coaching in the big Vancouver area. Without further ado, Dr. Marcus Robinson. I will share my screen for you, Marcus.
All right, thanks, Terry. And if I have a bit of a sore throat here, so hopefully this comes through okay. So I'll be talking on the new protocols on concussions. And so this is an update from the Amsterdam Consensus Statement that took place in late 2022. What I'll talk about is the consensus statement itself. And then I'm briefly going to touch on the diagnosis of concussion, more on the layperson type of view, and then get into the concussion recognition tool. Again, this is a bit more for those who aren't healthcare providers. So coaches, parents, teammates, those kinds of things. And then I'm going to talk specifically about some return to play protocols. Okay, so for those that aren't familiar, the consensus statement on concussion in sport was put together by a group first in 2001, where a group of experts around the world got together and said, you know, I think we need to have some standardization for what we're talking about with concussion and the diagnosis, the management, the treatment, and the return to play protocols. Since that time, there's been 5 further meetings, and the last one being the 6th edition that happened in November 2022. I was part of a subgroup in Amsterdam there with the collision sports representing lacrosse directly. But, you know, for those who haven't heard about it, I mean, this is a really the most rigorous scientific process that I've come across. It's, you know, there's a process for gathering together the world experts and a process for determining what topics are being discussed, what papers are being analyzed, and then there's an in-depth analysis of those papers, and then a really robust analysis and write-up of those papers. So really, if anyone in the world is not you know, on board with the consensus statement, then there really has to be a specific reason for that. So from the consensus statement, the most practical things that come out of it for us as healthcare practitioners and for lay people are the sport concussion assessment tools. So that's the SCAT. The child SCAT is there too, the concussion recognition tool. And then there's a new one that came out with the 6th version here, and that's more for the office assessment. So the SCAT is more for what happens in the first 72 hours. Beyond that, we get a little bit more in-depth of an assessment. And part of that is what Dr. Bauman was speaking about there. So this is the paper that came out of the consensus. And I just want to highlight a few names in here. Just being a proud Canadian, Catherine Snyder is from Canada. Carolyn Emery is from Canada. Winna May Wissa is from Canada. And I think there's one more in there from Canada as well. And Laura Purcell's from Canada as well. So Canada does, some really world-class research on concussion, and we should be proud of the work that we've done. So the next 3 slides are a summary of what's new for the 6th edition. And what I want to do here, I don't think we need to go through all of them in detail, but I want to highlight a few things just to pick out some things that I think are relevant for the group here today. So in this first slide, the fourth point here. So what the 6th edition tried to do was to start talking about strategies in terms of prevention. So the biggest one they came across was policy and rule changes. And what we saw there, again, work out of Canada, specifically out of the University of Calgary, was a finding that the concussion rates in youth were brought way down with, in youth ice hockey, were brought way down with elimination of body checking at the earlier age groups. So that was a recommendation that came out of this, is to eliminate body checking in lower age groups, and that's really brought down concussion rates. Another one that came out of it in terms of prevention is doing neuromuscular training and warm-ups, and that came primarily out of the rugby groups. And the recommendation there didn't provide specific recommendations, but there's a number of protocols throughout the, I was in a meeting with the NFL medical director a few months ago, and they're in the process of developing specific protocols with the football players as well. And really, those neuromuscular training programs should be done 3 times a week to have benefit with those as well. And then in terms of equipment, so nothing lacrosse specific that has been developed yet, but there is work being done on both helmets and mouth guards. Mouth guards in particular for hockey, but rugby is also developing new protocols as well. So in this second slide here, a few things I wanted to talk about. Number one is the results of computerized neurocognitive tests. I think a lot of us have been introduced to those, but one common mistake is that using the SCAT or any of these other tests are not diagnostic in and of themselves. They are tools to help inform both the diagnosis and return to play guidelines. So when you hear people talking about these tests, there's not a pass or fail per se, and really it's they're all part of a bigger picture in working on the management strategies for particular athletes. The fourth one here is one I think that's the biggest message that has come out of the 6th edition. In the past, we used to almost have people in a bit of a cocoon after concussion happened. So we'd recommend, be in a dark room and don't get exposed to any stimulus or physical activity. After I think about the 3rd edition, 3, 4, and 5, we realized that wasn't the best strategy, and in fact, allowing people to have some physical activity as long as it was sub-symptom threshold was the thing to do. By the 6th edition, there's been more evidence that early physical activity is actually part of the treatment. So not only are we allowing people to do that, but it's actually part of the treatment. Now, the caveat there is how much physical activity and how much extra stimulus. And that's where the medical team, including especially the athletic therapists, really come into play because they will guide that physical activity level. But the overarching theme of it is that you can allow for a little bit of increased symptoms. So on a scale of 0 to 10, if they increase by up to 2 out of 10, that's reasonable. And the symptom increase also has to be brief. So up to an hour is what's recommended as well. So that's the big thing that's coming out in terms of physical activity. The sixth point on that list there is in terms of cervical vestibular rehab. And I think Dr. Bauman actually put together a really nice slide in terms of those clusters. And really we're taking more of a multimodal and multidisciplinary approach now to concussion treatment, especially in the next one when symptoms start to progress past the 2, 3, 4 week mark. We really need to look at how are we clustering this athlete symptoms and who are the best or most appropriate specialists that will help with that. So Dr. Bauman really identified a whole host of clinicians or specialists that can be involved once we identify, okay, is this a cervicogenic type of cluster? Is it migraine or sleep? Are there cognitive issues there? Are there balance issues? Are there hormonal or autonomic issues as well? Then we move on here. I just want to highlight the first one here. And this is a question I get asked in clinic a lot after athletes have had more than one concussion, often from a parent, but they typically ask, how many concussions before my child or this athlete has to retire? And we're lucky to have John Grant Jr. and Dan as well to talk a little bit more on the athlete side of things. So I'll leave that for them, but I'll just say that there is no specific number. Really, it's that decision is complex, it's multifaceted, and there's would be many discussions that need to be made before a retirement decision is completed. So in terms of the non-healthcare practitioners that are in the audience today, one of the things as well that I get asked a lot is this a concussion or not? So a simplified way to determine if it's a concussion is that we have to have two components. We have to have a mechanism and we have to have signs or symptoms. So again, Dr. Bauman talked about a lot of signs and symptoms there, but a lot of those overlap with things that people already have. So mental health issues overlap with the symptoms of concussion as well. So in terms of a concussion, you can't just wake up with a concussion. You need a mechanism for that to happen. The other thing that we see too is that you can have a mechanism that's suspicious for a concussion in that an athlete takes a big hit, but that in and of itself does not determine a concussion. And in fact, there has been a lot of study to determine what is the impact needed to have a concussion, and that hasn't been determined yet. So there are a lot of factors that go into it, but athletes can take big hits and not have concussions. So just to be clear and just to reiterate, signs means things that we observe of the athlete. So we see them stumble or we see them lay motionless on the ground. And symptoms are things that the athlete experiences. So they experience confusion or they experience other symptoms like that. Now, one of the other tools that came out of this, again, for the non-healthcare practitioners that are in the audience, is how to recognize a concussion and what to do about it when you're not part of the healthcare team. So the biggest thing again, and this was something that's printed and readily available through the consensus group. First of all is recognizing it. And when you see an impact and you see an athlete that has had an impact, here at the bottom are the red flags that make us think that this is more than a concussion. And one of the things that we think about medically is a bleed in the brain. So a lot of these signs and symptoms that we see in the red flag box are things that would indicate a brain bleed, and that needs urgent care. Now, if they don't have any of those, we can go on to the next slide here. And on the right-hand side here, we see if there's no red flags, we can proceed as if this was a concussion. So again, visible signs and symptoms that the athlete reports. So these are visible clues. So when you're in the crowd, you're a parent, or just part of watching the game itself, you see somebody lying unconscious. If you see them falling unprotected, that's a sign. If you see a dazed, blank, or vacant look, that's a tough one to see unless you're up close with the athlete. But a seizure, or a posturing associated with a seizure is another example as well. The last one on here is a facial injury. And that one's put in there because it's not the facial injury itself that's the cause of concussion, but we can often be, look the other way when we see, a lot of blood from the nose or from the scalp, and immediately treat the blood, but forget about the concussion or the brain injury part of things. So I think we've gone through the symptoms pretty well here, so we can go beyond that. In order to, the first brief check is those 5 questions that you see under the awareness box. But the biggest thing to recognize, so when you do have that mechanism and you do have signs or symptoms, is that any athlete with a suspected concussion, now remember, this doesn't need to be diagnosed yet, but suspected, they should be immediately removed from the field of play and not return until they've been evaluated by a healthcare professional. The last line in that red part there is even if the symptoms were resolved. And so we do see that sometimes where a big hit happens, the person's slow to get up, they feel lightheaded or dizzy or seeing stars. They come back to the bench, they rest a minute or two, and then they say, oh, I'm fine. So if they've had a mechanism and they had signs or symptoms, they need to be removed until evaluated. And if there's nobody there that's qualified to evaluate them, then they cannot go back to play that day. All right. The last thing I want to talk about, again, an update for the 6th consensus statement, is a little bit of a change in how we do return to play. So it used to be a 2-step process in that the first step was symptom resolution, and then the second step was return to play. We used to wait until we said symptoms had completely resolved. By the 4th and 5th iterations, then there was some leniency in that and said, when the symptoms were low or minimal, then we could do the return to play protocol. Now, because of the change in thinking in that exercise is actually part of the treatment, and the allowance of an increase in a slight and brief increase in symptoms, there's a bit of an overlap now between the symptom resolution part and the return to play part. So really, we can actually divide step 1 to 3 into one category and steps 4, 5, 6 into another category now. Steps 1 to 3 is where exercise or physical activity is used as part of the treatment and the progression is monitored. In 4, 5, and 6, that's where we need to have symptom resolution and clearance by the healthcare professional. And since it's the heart of the NLL season, just want to remind everybody about the 2019 Calgary Championship.
I know, Dave, everybody's living in the past. Might have to show them the 6 ones from the Toronto Rock, but it's all good. We won't. Thanks, Dr. Robinson. We'll, I'll just stop sharing my screen here and see if there's any questions in the chat box. Claire, is that your hand up? Great, thanks, Dr. Robinson. So, Dave, if you can just mute for 1 second there. Alrighty, so our next presenter is Dave Murray. Dave Murray is probably the longest serving therapist in the NLL, starting back in 1998, Dave, or 1999 with the Ontario Raiders, and is still to this day with the Toronto Rock. He's a distinguished osteopath, certified athletic therapist, bringing over 28 years comprehensive clinical and field experience. In 2010, he established his Balance Osteopathic and Rehab Center in Burlington, which is a multidisciplinary clinic that reflects his expertise in treating a wide array of conditions, including sports injuries, chronic diseases, and neurological dysfunction. Dave, his academic journey was through Western and McMaster, and through the Canadian College of Osteopathy. So Dave's profound impact extends to professional lacrosse, as we said, and he's the athletic therapist since 1998 in the Ontario Raiders, and has come full circle, and now that they all play back in Hamilton once again with the Toronto Rock, and he has served with our national team since 2002, when I had my first opportunity to truly interact with Dave on the national team when we attended Australia. So I will turn it over to Dave Murray.
Thank you, Terry. We're just waiting for the screen to come up. There we go. Thanks again, Terry, and thanks to Dr. Bauman and Dr. Robinson. I'll continue on with early recognition of concussions that Dr. Robinson so eloquently and thoroughly went through already, but there'll be a couple other things that I will add to this. So in terms of importance of early recognition, it is critical. If we can gain early recognition of it, we can get early management of the concussion, diagnosis through a physician or through a nurse practitioner. And then once we have that diagnosis and early recognition, that in turn can lead to prevention of prolonged symptoms and then prevention of prolonged recovery. Again, which is critical for athletes, for students, for anyone. And then in doing so, we can decrease time to a safe return to learn and a safe return to play within that physiological parameter that Dr. Bauman talked about earlier. So once the symptoms are gone, we still have to make sure from a physiological standpoint that they are ready. So again, we're decreasing the time, but again, within those safe parameters. There are 5 components of consideration that I find are most important with regards to physiology. And first of all is when we get concussed or take a head injury, the first component is a cervicogenic component, and that includes whiplash. And so in consideration of that, it takes about 4 G's of force to cause a whiplash injury. And it takes about 70 G's of force to create a concussion. So anytime we have a concussion, or most often with a concussion, there'll be an accompaniment of a whiplash injury. And secondly, within our nervous system, we have different parts of the nervous system. One of them was those being the autonomic nervous system that have already been referred to earlier. But within that autonomic nervous system, again, we have the sympathetic and parasympathetic systems. And it's the sympathetic system that's the fight or flight. That stimulates us, gets us going. Then we talk about the parasympathetic system, which again is the rest and digest one. That's the calming one. After a concussion, with the trauma, it really stimulates that sympathetic system and creates all kinds of symptoms that have been previously discussed, and I'll run through again. But that's what stimulates us and can create that overload within our brain. some of the symptoms, if we go back, some of the symptoms, again, increased heart rate variability, changes in pupil size. And so some of these things that we screen for in the physical exam that we do that Dr. Robinson talked about a minute ago, again, will be assessed through and focus on that. Thirdly, a factor is how the concussions affect the metabolic system, creating inflammatory and hormonal changes. And some of those, again, would be addressed by a physician. Dr. Bauman referred to Dr. Comer earlier about with concussions, and that's what that he dives into with his concussions is more so the hormonal changes. And so, but you also have the inflammatory effects. And so a lot of these can be affected by and caused by gut dysfunction. So really focusing on that as well. Fourthly, the vestibular and ocular motor systems, again, have been referred to either earlier, but again, vestibular system refers to the balance or sense of balance. And often that is definitely affected through the types of head injuries that we get and through the mechanisms. And then ocular motor changes. So we have different types of movements within our eyes that we test for and look for, and that can be altered again and really affect what we're taking in. So 55% or over 50% of the things we take in sensorial wise come through our eyes. So when movement of our eyes and the ability of our eyes to focus and so on changes, that can really affect our overall being. And then fifthly, the psychological component, which again is so extremely important throughout the whole process. And I know that's going to be discussed later on by our sports psychiatrists, so I'll leave that to them. But again, it is of critical importance. So early recognition. So a big thing that Dr. Robinson talked about too is the mechanism of injury. Is there a mechanism? And it's an acceleration, deceleration mechanism where we hit something or something hits us and causes that movement of the brain within the cranium. There's also the rotational component that in many cases occurs as well, not always, but that definitely is a factor involved in this. And so these next couple slides, I just wanted to show how we see these. So this first slide, many of you remember or potentially remember this hit, and you see that direct hit to Sidney Crosby's head, and that really, unfortunately for him and maybe fortunately for many others, have helped in promoting concussion recognition and so on. So you can see that direct hit to his head, and there's also that rotational component. And then he laid on the ice there. So that's something that we want to consider too after an injury, early recognition. Are they able to get up? Are they moving? How are they responding immediately after? And so if we move on to the second one, if we watch closely, this hit, we don't see any hit to the head. And if we see it in the next slide in slow motion, if you look closely, there's no hit to the head. It's just an acceleration, deceleration injury. And in fact, that did lead to a concussion. So again, no real direct hit to the head, more to the chest and sternum, but with similar result of a concussion. So when we're looking for these things, it's important that we recognize that it's not just any hit to the head, but it can happen outside of a blow to the head. And then so removal from play, when we recognize these injuries, signs that would warrant immediate removal, again, loss of consciousness, seizures, tonic posturing. So when you see someone, one of the football players last year, Tua Tagovailoa, I can't even pronounce his name well, with Miami Dolphins, I remember, if many of you remember seeing him, hands were in a tonic posture where they are extended. And so those types of things where they're either extended, hands extended, limbs extended, or flexed in different positions, definitely not a good thing. Ataxia, so just changes in movement, poor balance, confusion, behavioral changes, and amnesia. All of those would certainly warrant removal from play, and that's not an exhaustive list. Certainly other things would lead to a removal as well. Those are key ones though. And then signs and symptoms. Again, Dr. Robinson, Dr. Bellman have discussed some of these. A couple of them that I'd like to highlight. One of them is feeling like you're in a fog, and then number two is sadness. And these were described by another Dr. Robinson from Western University in his studies. He found these two particular ones were signs that could lead to prolonged concussive symptoms. So again, not just these ones, but those ones were ones that he kind of deemed out. And reasons for immediate referral to an ER, again, discussed earlier, but worsening headache, vomiting, changes in cognitive status, decreased alertness, bruising under the eyes or behind the ears, loss of balance or coordination, severe neck pain, difficulty speaking or understanding speech, seizures, again, loss of consciousness, tingling or numbness, weakness in the extremities, or changes in vision. And so again, getting back to the early treatment, this will be my first slide, but early detection, early diagnosis, again, through a medical doctor or a nurse practitioner, can lead to early treatment from a variety of different types of medical professionals. And then that ultimately can lead to a quicker and safer return within the physiological time frame. And again, the research is, again, this list isn't exhaustive, but there's definitely been research that has focused on that. And so, yeah, on that being said, I'd like to thank you and look forward to hearing from the rest.
Thanks very much, Dave. Sorry, just asking me. I see Dr. Bowman has just gone off screen here, so maybe I might be able to ask this question from the chat to Dr. Robinson. Based on the new technology being developed, does the Q collar actually prevent concussions?
So I did an extensive search of the literature about 2 years ago for the NLL for this particular question. And at that time, there wasn't sufficient evidence to support the use of this product. However, I can tell you that both the NHL and the NFL are looking at it, and there will be more conclusive evidence in the next year and a half or so. The NFL is looking at it just as purely a mechanism to try to reduce concussion. The NHL has a more pragmatic reason in that they have an approved list of equipment that the players can wear, and so they need to put it on or off, on the approved list or on the banned list. So that's why they need to do the research to look into it. So we will get an answer probably in the next year or so.
Thank you. Greatly appreciated. Thanks, Dave Murray. Greatly appreciated for your presentation. We are going to move from the Toronto Rock now over to the Rochester Nighthawks. We welcome Steve Lopsinger. He's a certified athletic therapist, and he's also a manual osteopath from Waterloo. Steve has been around the league for a long time. He's started with lacrosse in 2005 with the Kitchener-Waterloo Kodiaks, and he's been with the Six Nation Chiefs, vintage Chicago Shamrocks. He's also been with the Toronto Hamilton Nationals, the Rochester Nighthawks, and has represented us many times. I think he's 7 or 8 times now with Team Canada. And we will welcome Steve Lopsinger.
Good evening, everyone, and thanks for having me. Oh, actually, that's Erica's Dave, or Terry rather.
All righty, give me 1 sec. Which one is yours?
Right here, back one. There we go. All right. Like I say, thanks very much for joining us this evening. We certainly appreciate you guys taking your time out of your busy schedules. So once our athlete has received a diagnosis of a concussion from a sports or family medicine physician or nurse practitioner, and we've ruled out more serious head and neck injuries, how do we safely and efficiently return that athlete to play? Firstly, as we've already stated, it's important to allow our athlete a brief period of relative rest or inactivity for 24 to 48 hours prior to starting treatment. Concussions are variable. Therefore, the treatment of concussions should be variable as well. What works for one person may not necessarily work for someone else. We need to keep in mind that not only do concussions affect physical performance, but they can also affect mental performance as well. It's therefore important to limit any activity that makes the symptoms of a concussion worse. This means limiting or excluding physical activities, such as gym or organized sports. We may need to reschedule tests and exams and reduce homework to shorter increments as tolerated. And this speaks to the importance of the continuity of care and necessity for open communication between the athlete, parents, coaches, and teachers. So as has already been stated, unless directed by a physician, athletes with a suspected or diagnosed concussion should not take medications such as aspirin, anti-inflammatories, sedatives, or opiates, consume alcohol, use recreational drugs, or drive a motor vehicle. We just saw a couple great videos demonstrating the dramatic events of a concussion, the high rates of speed, the significant forces and violent impact. Concussions are quite simply traumatic. It is because of these extreme forces that other areas of the body are often affected. Clinical treatment of a concussion by a healthcare practitioner should address these secondary injuries, such as altered head and neck range of motion, things like whiplash and muscle spasm, whether it's TMJ or jaw pain and discomfort, as well as balance, vision, and coordination challenges. As previously stated, we can't forget about the effects of a concussion on memory, concentration, and cognition, not to mention mental health. The vestibular oculomotor screening is used to both test for and treat balance and vision problems, noting deficits in how the brain processes that visual and environmental information. This treatment modality is used to help retrain the brain following a concussive injury, helping with spatial awareness and dizziness associated with head and eye movement, and can assist with focus, balance, and coordination, not to mention gross and fine motor skills. Some of the symptoms of vestibular or balance issues in ocular motor or vision function include things like dizziness, nausea, fatigue, brain fog, headaches, abnormal gait or walking, and neurocognitive impairments such as short and long-term memory and concentration issues. Next, we get into things like craniosacral therapy, which is a very gentle and passive modality that seeks to restore and balance the movement of the various bones of the head and face. Well, many of us were taught in school that once we reach our mid-20s, these cranial bones fuse, forming a singular hardened skull. Manual osteopaths believe that every bone has a specific movement pattern based on the orientation of those cranial sutures or the joints where those bones interact with one another. Traumatic events, such as car accidents, falls, body contact, that are significant enough to cause a concussion often result in altered cranial mobility and rhythm. Therefore, treating the cranium may prove beneficial in alleviating many of these concussion symptoms and aid in restoring health. We've already talked a little bit about subsymptom threshold training. So as our athlete progresses through the rehab process, it is important to slowly and safely, for that matter, increase the intensity of exercise with the goal of returning that athlete to the level seen pre-concussion. By putting our athletes through a treadmill test of increasing intensity and making note when there's been a change in the athlete's symptoms, We can establish a safe heart rate zone by which the athlete can exercise in. This provides them with all the physical and mental benefits of returning to activity, but also aids in the treatment of a concussion as well. As was previously stated, we know that concussions disrupt the autonomic nervous system. We have a depression of the parasympathetic nervous system and an elevation of the sympathetic nervous system. But the great part about exercise is that it actually helps to normalize and rebalance, recalibrate that autonomic nervous system. Thank you very much.
Thanks, Steve. Sorry, I got a little bit out of the rhythm there. It was supposed to be Erica Busk up next, but Erica is going to defer to Claire so that we stay in her flow there. So Claire Biafor is a member of Lacrosse Canada since 2021. Her love for lacrosse began at York University when she was selected to be the assistant therapist of the men's and women's lacrosse team. Since then, Claire has successfully completed many different practitioner. She's a massage therapist. She's a CAT, medical acupuncture, master's in kin. Currently, Claire is a head therapist of Lacrosse Canada's U20 women's national team, sixes, and field. Claire traveled to Maryland this past year and also Alabama with the World Games, where she won a gold medal to support women's field. Welcome, Claire Biafor.
Thank you, everyone. It's an honor to be here, honestly. Thank you so much. So we're going to do a little bit of a general overview about some treatment protocols that can be applicable following concussion. Please be mindful in a couple of different things. It should only be used to manage symptoms following a concussion. It's best used in combination with other treatments and interventions. It should only be performed by a licensed practitioner and under the direction of a physician. And some possible treatment intervention options will include things like athletic therapy or physio, osteopathy, massage, and acupuncture. So when we're talking about massage therapy, it should only be focusing on the muscle mobilization related to the symptoms of a concussion, including TMJ and neck. And so far, we've had a great overview from Dr. Bowman, Dr. Robinson, from Dave, from Steve. So you can see that there is a general focus on managing signs and symptoms. Neck treatment is important as the kinematics related to head displacement during a concussion involve resulting neck tension. And so Dave had some great videos which really articulated this in managing or in determining whether a concussion occurs. In addition, focusing on general manual techniques, including things like myofascial treatment, trigger point treatment, and various massage techniques. These techniques will change from an acute to a chronic stage of concussion management. So if we're looking at initially following a concussion and under the direction of a physician or a medical professional, there should be more softer and gentler techniques, including the myofascial treatment, which is a little bit more of a generalized, very soft treatment technique, and then moving into something slightly more aggressive. Acupuncture has also been found to help with headaches, sleep disturbances, anxiety, depression, and pain. And so acupuncture is just a series of finding trigger points in the body, and trigger points are just active areas of the muscle that are a little bit unhappy following a concussion. And so using acupuncture points and using acupuncture needles to help minimize those trigger points. Treatment may include various points surrounding, and it can include around the head, the face, the neck, and the shoulders. And lastly, it may help in the releasing of trigger points within a tight muscle following the concussion, as I previously stated. Thank you, everyone.
Thanks very much, Claire. Just give me 2 seconds here. We will go back, as I unfortunately did skip over Erica. Thanks. So Erica Busk, she is a certified athletic therapist and yoga teacher from Kingston, Ontario. She started working in lacrosse in 2016. But her love of the game started when she played field lacrosse in high school. Erica has worked as an athletic therapist for Team O from 2018 to 2022, and then joined Lacrosse Canada medical staff at the senior women's national team at the 2022 World Championships. She's currently working with the U20 women's national team, and we'll be accompanying them in our drive for gold in Hong Kong in August 2024 at their World Championships. And we welcome Erica Busk.
Thank you, Terry. So I'm going to speak to the importance of the continuity of care once a concussion has been identified and diagnosed in an athlete. So Dr. Bauman mentioned initially that there's a number of practitioners that may be involved within the treatment and the identification of a concussion. And we would refer to those people as members of the circle of care. So that might include the athletic therapists with the team. That could include, sports med docs, sports psychologists, massage therapists, acupuncturists, all of the sort of treatments that have been discussed already. It is incredibly important for all of those people that are involved within that circle of care to be on the same page and to be communicating effectively through the whole recovery process, whether that, is relatively quick or it's one of the longer sort of delayed processes that can occur. This is achieved, as I said, via communication, more specifically documentation. So whether these different people sort of already know each other and can be in contact that way, or whether there's doctor's notes being shared or copies of, the concussion recognition tool or SCAT-6 and sort of seeing those results. And that can be shared then with everyone that's part of that circle. There are easier ways potentially to facilitate that communication rather than hard copies being passed around or emails being exchanged. There are some apps, specifically there's one called Privet that we here at Lacrosse Canada will be using. And basically what happens with Privet is, let's say I have, the account and there's an athlete who's working through the return to play process and they come to a practice. I'm able to see via that Privet app what they did at the previous practice, maybe it was last day or last week, whenever we saw them last, and what stage they were at in terms of that return to play, as Dr. Robinson talked about with the heart rate changes and then all the way up to a full contact practice and then game. So we're able to see that within that app, and then I could then make my own notes about what we did next in that stage, and then whoever sees that athlete next is able to see all of that information. So just an example to sort of take it right from the get-go all the way through. Let's say Taylor is a 17-year-old lacrosse player who has sustained a concussion while playing for their club team. As we all know, many athletes will play for a club team, school team, maybe a travel team, or maybe they're multi-sport athletes and they're also playing hockey or something else. So there's an athletic therapist at this game. They were removed from play, and then they went to see their family doctor to get the official diagnosis that, yes, they do have a concussion. So as I said, they play lacrosse in their school team as well as another travel team. And Taylor's parent makes sure that there is communication between all of these relevant parties. So the communication from the family doctor, also maybe the SCAT that was brought to the doctor to see that. The school coach is maybe aware then of that, or if there's like a school nurse, the travel coach or medical staff then become aware of what's happening with the diagnosis and the symptoms. And then the club team coach and medical staff is also made aware. So it's really important to have a point person kind of take the lead for this communication. In that case, it's a parent. We may hit a point where it's maybe the team athletic therapist that's taking the lead in terms of that communication and making sure everyone is on the same page. And it may be the athlete themselves in some cases. depending, we know some high school athletes aren't always the most reliable with these types of things. So discretion can be used in, case to case basis, but it is really important to have someone who's sort of the hub that can send the various spokes out to the relevant parties. So to continue with the example, Taylor starts to receive treatment. Maybe that's massage, acupuncture, who knows? And they begin the return to learn and return to play processes. So we make sure, as was said already, that returning to learn and returning to school fully is the priority before returning completely to their sport or to lacrosse. The Taylor's parent continues to make sure that all of the teams and all of the relevant medical staff are aware of the progress through that return to play protocol, what stage they're at, how it's going, symptoms that may be evolving, maybe symptoms that may be hanging around. And then, as the next point mentions, the return to play process is going well, but they continue to have some lingering symptoms. So let's say, for example, they are fearful of, being hurt again, sustaining another concussion. They're just not quite ready to get back in there, even though they may be ready in terms of the process. This is where the circle of care may expand beyond who we already have, to bring in a sports psychologist or a sports psychiatrist who might be able to then help resolve this symptom. And again, just reiterating, then that circle of care, as I said, expands, and everyone still needs to remain on that same page with that very clear communication. And that's it for me.
Thanks very much, Erica. And we're going to turn to our last therapist before we turn over and speak to John Grant Jr. and Dan Carey. Our final therapist here is Tyler Quinnell, who's been a sports medicine practitioner for over 23 years with varied teams across multiple sports. He presently holds a position with the Toronto Rock Lacrosse Club of the NLL and has been involved with the Canadian national team since 2017. The Heritage Cup, most recently, he was with the National Sixes team that won gold at the World Games in Alabama. Tyler is proud to serve as the head athletic therapist of the team and in Canada's men's box lacrosse team here in 2024 in Utica, New York. I'll turn it over to Tyler, and Tyler, let me know where your slide starts.
They will start, I believe, after Claire's. And thanks for having me, Lacrosse Canada. Thanks for everybody who's joined us this evening. I'm excited to talk about it. So this one's good, Terry. So we've had a lot of great presentations here, especially from our two physicians at the beginning and the therapist. You can see we're all kind of on the same page. What I want to talk about is the recognition, but not necessarily of the concussion, but the back end of the treatment, where it's the return to play, and we're going to start going through a few of the steps. So once the athlete gets removed for the concussion and we use that concussion recognition tool, or they are assessed by the healthcare practitioner, that relative rest is great. That's what Stephen Lobsinger was talking about, the 24 to 48 hours. And Erica had just mentioned returning to school, because healing times are going to vary person to person. And with each concussion can be different. Just because someone has had one even a year before, 2 years before, some of the signs and symptoms might actually be different. And there are a lot of factors that will go into that. But once they start returning to play, and we can go into the next slide, please, Terry, there are certain things to watch for, and there's a bit of a process. So I've included the link here for Parachute. And as Dr. Bauman said, there are some updates that are going to come. So it is a good site. There's actually a lot of information there, and it's a good one to check back with, especially, unfortunately, if somebody has a concussion. But after that first relative rest, step 2 allows for that athlete to begin the light aerobic exercise, which research is showing is very important with returning to learn and actually returning to sport. For lacrosse, that can mean simply going and walking around the field. You can walk around the block, you can walk around the field or the rink, depending if you're field versus box. walking is a good start because there's not a lot of up and down with the head like a running. There's no sort of that cadence of up, down, and which essentially is the head bouncing on top of the neck. So as you start to progress with the walking, usually what we'll suggest is an exercise bike. So as Dr. Robinson had mentioned with step 2, this is something that can be monitored by a healthcare practitioner, someone who is looking at relative heart rate and blood pressure and making sure that the symptoms don't return. The signs and symptoms might return, but as we had said, what we're allowing now in terms of the research is on a scale of 1 to 10, a 2-point bump for no more than an hour after the exercise. Once these sorts of things are starting to rectify and under the direction of either the doctor or the healthcare practitioner, we can start to progress onto other steps. So step 3 is that individual sport exercise. The player can start running with their stick, running with the ball, doing the stick handling, nice straight line stuff. They can progress to a wall ball routine, and a lot of Lacrosse Canada athletes actually have good videos on Instagram, things like that get promoted all the time on different wall ball routines. They can simply move to a standardized wall ball and then get more complex. Once they start shooting, they can just shoot for the net, start picking corners, and all of this progresses to things like shooting on the run, after a dodge, starting to initiate different moves within what they would be used to back into a practice or a game. The goal is always to start really simple and then move to the complex. It's always easier to add a little more, and athletes will get discouraged if we have to say, no, you have to come back. I always tell my own patients, we can always do a little more, we can always add a little more until we've added too much. So everyone being different, sometimes this is a bit of a sticking point where you need to find out what the athlete is doing and how much are they doing outside of what you're watching and what are their symptoms like. Yeah. So once they can do all of those things, we're back to practice, which is great, sort of. One of these things that we're able to do, is, as long as there's no new or worsening symptoms, they can return to practice. But this is maybe just a part practice because everything should be individualized. The coaches might be able to say, okay, if we use Erica's example of the athlete Taylor might have an individualized practice plan. So obviously, as we go back, all contact should be avoided because what we're trying to do is incorporate all of the different systems that we've heard about today, the vestibular, the oculomotor system, even the muscular system, as we start to run and pivot and turn our eyes and move our heads to follow the ball and watch for players and passing and catching. All of those things obviously need to be that simple to more complex. And then as you're progressing through, as Erica mentioned, we're going to continue with that continuity of care, and everybody needs to be kept in the loop. Were there new symptoms? Did they start to worsen? What can we add in now? Once we go back to full return, it's that practice first. Nobody's going to go back to, or no one should go back to a game right away, provided the athlete has been moved through each stage with no problems. A medical doctor note can be obtained to return to a full contact. You have to make sure that the athlete can take that contact before we put them back into a game, or we risk missing a sign or symptom that would essentially open them up to a new injury. So it's pretty easy, but they need to know about being hit and how to take one and how to give one. Everyone's going to recover through these steps at a different pace. So everyone just needs to have patience. That is the therapist, the parents, the athletes, everybody. It's okay if that athlete needs to regress a step because, as I keep saying, everybody's a little different. It takes time for the brain to figure it out, figure itself out. Lots of things are going to contribute to or delay some of that healing, the treatment, the auditory stimuli, things like that, returning to school and all of the cognitive stress that we're putting the brain back under as it heals. So that's that's kind of it. So I'm going to pass it back to Terry.
Thanks very much, Q. Don't see any questions in the chat here. So we're very lucky. We presently have, unfortunately, they're both Peterborough Lakers. So that could explain a lot with regards to concussions. But in all seriousness, we're lucky to have Dan Carey and John Grant Jr. Joining us on behalf of former players that have played with concussions and maybe had their careers cut short a little bit due to concussions. So if we're lucky enough, we'll get Dan Carey to kind of start here with us. Dan is the president GM of our men's fields, both senior and U20 team, and he's the present GM of the Rochester Nighthawks. Thanks, Dan.
Thanks, Terry. I appreciate everybody that's presented here today. You know, a couple that I'm pretty familiar with and have worked with, you know, over the last few years. So I really appreciate what you guys do. You know, as far as me and John from Peterborough, hopefully we don't need an interpreter, but we'll get through this as best as we can. So I'd like to kind of go through my experiences, starting from youth lacrosse and hockey, you know, when I was 4 years old. You know, during my youth, I don't remember, you know, I remember hitting my head a lot. There's a lot of times where, you know, as a smaller player, I would be carrying my helmet to the bench all the way through junior lacrosse, sometimes even in senior and pro, but just loved both sports. Wasn't really familiar with too many of my teammates or anybody at the time going through concussions. You know, Eric Lindros is a player that comes to mind that, you know, I think at the time everybody was aware of his situation, but the educational part of it just wasn't there. So fast forward a little bit, I started my NLL career in 2006, playing in Colorado. You know, I was fortunate to play on some good teams there. Was fairly lucky to be healthy through my career to that point, still being a fairly young player. But it was 2008 was my first concussion that I'd ever kind of dealt with that was known. I'm sure there was a few times that you know, you kind of get your bell rung and maybe I was dealing with something at some point, but that was my first known concussion was in 2008. I was in Portland, and something that I didn't do on a regular basis, if ever. But there was a few players in their team that were towers and much bigger than me. But I decided to spike one of the players with the top of my head. Again, not something that I was used to doing or had done it really at that point in the NLL, but made a bad decision on the floor. So my first concussion was basically my own fault. So I ran into a player. Continue to play throughout the game. And I think, you know, going back to that educational part of it, I didn't know, there wasn't a point where, you know, we had kind of learned, like, take yourself out. You if you feel different, if you feel those symptoms, it just wasn't something that we were as familiar with as we are now. So I continued playing through that game, was diagnosed with a concussion after the game, and we had a bye week. So I had 2 weeks off, flew back to Peterborough, spent some time resting, and a few days later, you know, working with our medical team, I was kind of back to doing some light workouts, some jogging, some running. And the thing that they kept asking was, do you have a headache? And I didn't. It wasn't a headache. And I think that was one of the symptoms that was somewhat, you know, common, and you know, you could easily kind of define that headache that you had. So I didn't have a headache, but I was off. I felt different, and it wasn't, you know, complete fog at that time, but there was something there that was, you know, not as familiar to me and not that comfortable. But as an athlete, you kind of go through your youth and get to professional, and you kind of take pride in trying to tough through things, right? You fight through it, and you battle through some injuries. But it wasn't, you know, it wasn't something that was glaring and difficult to deal with. It was pretty mild at the time. So played 2 weeks later, actually, ironically, against John Grant in Rochester. It was in Colorado, but against Rochester. So 2 weeks later, doctors cleared me to play. I felt pretty good. I could run, I could do some workouts without really having any additional symptoms, but I was still off. I don't really remember if I was communicating that properly to our medical team, or if it was just, hey, we're not seeing any major symptoms. This was something that, we felt like I was okay to play. Hindsight, I wasn't. There was something still there. So first quarter took a hit, and you played the rest of the first half. I came in the locker room, and just my head was spinning, very nauseous. Ended up, vomiting in the middle of the locker room with the garbage. It was not good. It was a bad scene. But I was unwell for about probably 3 months. Symptoms that Dave, I don't know if Rainer, if you're able to pull that back up, but I think it was Dave Murray that had up on the screen. And just as I'm looking through it, I personally had every one of those symptoms. It was a very difficult time for me. And again, not being educated on it, I think the biggest thing for me was I wasn't completely healed. And I think that's ultimately the goal of these professionals that are on here, to make sure that we are educated with, ourselves and our youth players and everybody that we're helping and involved with. It's making sure that we are cautious on the return to play. Because I feel if I had waited another couple of weeks, I probably, would have played a lot longer than I did. Again, a lot can happen, but every one of these symptoms, it was something that I had dealt with. And it took me a while to get through them. So that was in 2008. I came back in 2009 and just was never really myself. I did a lot of rehab. So there was pretty much anything I could do to try and help, I was willing to do. So, I think one of the doctors or athletic therapists mentioned acupuncture, massage therapy. I was doing vestibular rehab. So a lot of it was, at a point, my eyes I wasn't able to focus properly. So there was a lot of, kind of work that I was willing to do and trying to do. Saw a lot of medical professionals and concussion specialists that were trying to help with this. But it just took a long time. So I came back in 2009, the following season, and I only played 4 games that year. There was some that was starting to become related, or what we thought was related to my neck, and trying to kind of work through all that with chiropractic work and different things. So it was, I would say, about 2.5 years. That was a really difficult stretch, trying to work through the symptoms and finding something that would help get me back to feeling normal. So I think it was the end of the year that I played a few games, played a playoff game in 2009 when I was in Colorado, and felt good enough, felt like I was back to normal. And I think, the whole process of an athlete and somebody that's, you're training on a regular basis, you're doing a lot of, intense workouts, and you're very active, going from 100 to 0, right? You're just, it really makes things a lot harder to get back to when you take a significant amount of time off. So I was kind of on and off, decided to play in the summer for Peterborough in 2009, took another hit, which we considered, I guess, my second concussion. And that made me basically miss the entire 2010 season when I was at Colorado. We got to the fall of 2010, leading up to the 2011 season, and I was ready to retire. And what really worked for me was craniosacral therapy. So I was introduced to Andy Player's his name. He was the trainer for the Toronto Maple Leafs at the time. It changed my life, and I think there's different things that will help different people. But that was something that I just was dealing with, this fog every day, and it wouldn't clear, and I could do whatever, I'd try to do, and things would help, short term, but it never cleared me. And the first session that I had with him, within 15 minutes of leaving, I was a different person. It was incredible on, a lot of different levels, but just the mentality that I had, there's a lot of optimism about playing. And at that time I was all about playing lacrosse and trying to get back to doing what I love to do. Knowing that I was educated, working through, a lot that, a lot of people had kind of helped with the understanding that this is, something that can affect your long-term health, and, wanted to be cognizant and really focused on that, but at the same time doing everything I could to get back and play. So it was until, I guess it was just over a year and a half, kind of getting back to feeling normal. And he worked with me in 3 or 4 sessions. Got back and played 2011, and I think it was 2012, and I got traded to Toronto. Got my 3rd concussion. Ultimately, the doctors felt that it wasn't smart for me to continue to play, and hindsight, it probably was the best idea and the best approach when it comes to health. But it was a tough road for a lot of years to try and get through it. I worked with Dave Murray and Stephen Lobsinger. Those two really helped throughout the process. I think Dave, probably saw me on the table every week when I was in Toronto, and those guys, they really helped, the two of them. And I think even to this day, with Robert being in Rochester, every now and then I'll have him work with me. And so I think, from my standpoint, there's so much that we were uneducated on, back when I played, that there's the knowledge and understanding, the expertise and the education that we have available to us now. It's so important to give that extra time, make sure, we're doing right by our players and keeping them safe and healthy. And, but educating the players, I think, is probably the most important thing. If I had known, personally at the time to a little bit advocate more for myself, give some extra time in between, then, I think things may have changed a little bit. From my standpoint, there's some things that I still feel like I manage, but I wouldn't say I have long-term effects. I don't know if it's just getting older or if it's just, the nature of what I do and kids and everything else that gets put into play. But there's some things that, I think, again, flying, I was never, anytime I flew or went through turbulence, it never bothered me. And now I feel like I'm going to fall out of the chair. So there's definitely some things that I think, have been affected, long-term when it comes to my health, but I continue to manage it and get work, with craniosacral therapy, massage therapy, trying to keep up on chiropractic work. It really helps me. So, again, I think from my standpoint, anytime I can help and become more educated for myself, but also help and have conversations with people to realize the importance of doing the right thing, giving extra time for players to return to play, is extremely important. And, I think it's great that we're doing this. So again, Terry, I appreciate you going through this process and everybody that's contributing to this. And, I appreciate you asking me to come on.
Thanks, Dan. We do appreciate you sharing your story. And if you're good with this, I'll have Junior come in, because I think maybe we'll open some questions up at the end, because there might be some overlap amongst the two of you. So if you're good with that and can hang around for a few minutes while we hear Junior's story.
Absolutely.
Thanks. So John Grant Jr. doesn't need too much of an introduction in the lacrosse world. We're lucky to have him so many years as an athlete, and now we're lucky to have him on board as a coach. And his first time he steps on the field as a coach, he wins us a gold medal. So we're kind of hoping that tradition is going to continue here in 2025 when he takes the field as an assistant coach with our men's team. But as many know, John has struggled in his day with concussions. And Junior, if you'd maybe just share a little bit of your story with us, that'd be great.
Well, thanks, Terry. And it's kind of crazy. You get on a call like this and you have, I think, 3 therapists that had to deal with me. One of my best friends who ended up being my GM, working with Terry. I think I saw Eddie Como, my favorite coach, is on here somewhere. I've been wanting to be a part of Team Canada since basically I was born. My father played. He was on that Miracle 78 team. And lacrosse obviously has been a passion of mine my whole life. And I've played 44 years of lacrosse. So because we're all athletically inclined, or at least love sports, we're going to have a competition to start How many concussions in my 45 years of athletics have I been diagnosed with? Throw it in the chat. And the people that know me, you can't answer. Little competition, get things riled up here.
When we got 8, 3, 5, 10. I'm gonna go with one really long one, but
Pretty good. Pretty good. Well, the answer is 1. And I know for a fact I've had, I mean, I don't know the number. A lot of the concussions I had growing up, and I'll go briefly, just like Dan, back kind of the origin story. Like any rambunctious kid, I got hit by a car, fell off a deck, hit with a baseball bat, you name it. T-boned in the car, fell out of a moving car, played lacrosse with no mask because I'm that old. And it just on and on and on, throwing up through my mask in hockey, falling and hitting my head on the ice, fighting with my parents because I said I wouldn't play with a helmet on, that whole thing. So years and years and years of head injuries. And I can honestly say, other than the one that retired me in 2017, was the only time I remember having so-called what I thought in the old school world symptoms: headache, dizziness, vomiting. So all growing up, I had my bell rung and all, like, I'd have a headache for a little bit, but I'd always be fine, and never really. And I always used to always brag because I was always perpetually injured. And the trainers on here know, back surgery, 10 knee surgeries, broken leg, the whole, but I always I must have a rock head. I'd never missed any game for a concussion. Never missed. Knew I had them. And it wasn't until, I started getting older into my 40s where they started to hang around a little bit. But if anyone knows lacrosse, you play, you go out and celebrate after, and Sunday is usually kind of a write-off. And sometimes Monday, you've trained all week to play, you've given everything you've got, and then you hang out, you celebrate the win or the loss with your teammates, you travel. Monday's a recovery day. And then sometimes it got into almost Wednesday where I would just be still in bed, depressed, blinds drawn, can't answer the phone. Just chalk that up to just being old and exhausted. And that's life in the NLL. I got lucky that I was able to play and not really work. So that became my life for pretty much 20 years, other than going to therapy. I couldn't really train because of my knee, so I didn't really suffer like that kind of injury through the week. I just was always able to play week after week after week. Summertimes it'd be Peterborough, Canada, and then MLL. So there'd be like 45, 48, 49 games a summer. And you just were so focused on lacrosse. And a lot of this stuff now, I remember looking back, I didn't remember it then. And my wife, who's a saint for putting up with me for 25 plus years, every fall, from the year I started playing pro 2000 to, well, still now, every fall it would hit. I would be depressed and sad and anxious and miserable. Behavior changed. And I always just wow, I miss lacrosse that much that I'm not playing lacrosse. Fall's the only time we never played. So it was always recuperate from injuries, but didn't think anything of it. Called it my own kind of seasonal affective disorder, so to speak. Finding something to do to compete just to take my mind off of things. So fast forward, like I said, never missed a game. I'm the old school idiot that, would purposely not do well on the concussion preseason exams in case I did get tested. But I never did. I never, ever got one. And I mean, the Toronto Rock caused quite a few of them. But it wasn't until 2017, and Dan Carey was the GM of the team, and I was hanging on to a career barely as is. My other knee, I had surgery on in that fall, and Dan is younger than me, but have to have a conversation. I remember it like it was yesterday. It was him and Steve Govett saying, can you do this? And I'm like, I can do it. Made it 2 games into the season, and I think I got probably 3 headshots in that game. And my wife can attest to it. That was the first time I said, let's go home right after the game. I'm like, Colorado, real famous place to go hang out in the restaurant after and hang out with the buddies and the fans and the other team. And I'm just like, we need to go home. Didn't realize, drove the whole way home with my lights off, the headlights. It was about a half an hour drive. And that next day, same thing, in bed, miserable. I had a daughter at the time, still have a daughter, but they knew not to really bother me on Sunday, Monday. Wednesday came around, I was still struggling. I called in sick to work. I was coaching at a prep school in Colorado. And then something happened where my wife asked me to do something innocuous, harmless, and the only thing I can think about was there was 27 people screaming at me at the same time. So I kind of like had no idea what was going on, kind of like put my elbow through the drywall, got my car and drove 45 minutes away from work and didn't know why I was there. And I ended up calling the trainer and said, there's something seriously wrong. And I was obviously very emotional. So went into protocol, realized right then and there, obviously everything on that list and beyond, but I still didn't have a headache. But the dizziness I definitely had. Couldn't stand up. If I closed my eyes, I'd fall down. So I went through every therapy, but still, needless to say, I tried to get back as soon as possible. That was like, missed 1 week. And then I went to the gyro stim where you spin around like the astronauts or whatever. And the thing got stuck. And it's kind of a funny story, but it's got stuck with me upside down. And I started screaming at the guy, fix me, it hurts, it really hurts. And he made a comment, oh, you probably have a bleed. MRI went, got a look, and I had a microhemorrhage in like the left side. And needless to say, Dan and the team, the doctors took very good care of me. And they're just like, this isn't going to work. And it just never got better. And it was a couple of years, and I did every therapy, saw like a psychologist, saw ocular, vestibular, speech therapy. My speech was gone. My short-term memory was gone. So it was, to the point where I was very fortunate. I worked in a athletic department at this prep school in Colorado with 8 players from the NFL were on the coaching staff of the football team. And I was in my office and the lights were off. I was taking what was called a brain break at the time. 20 minutes, everything shut off, earphones on, head down. And he came in, sat down, closed the door, and he's like, how are you doing? And I guess it was getting around the school that my behavior had changed, and the kids were starting to get concerned and a little bit worried that, my temper was crazy and all this stuff. And he sat me down and talked about his story and how he was able to live in the guest house. Obviously, they made more money, the Broncos did, than we did. And he said for 9 months, he spent 9 months in the guest house because he was afraid of what he was going to do in the big house. So I'll never forget it. Very, very helpful. And, needless to say, I had to retire. The Mammoth did right by me and took care of everything medically. And needless to say, I thought I was done, retired from both, started coaching. I came back a couple years later, but that's beside the point. But now, since then, I've had probably a half dozen, like just fluky things, hit with a ball in practice, slip and fall on the ice where I didn't even hit anything. Like they happen so much easier now, when before my whole life, I'm like, I could literally hit my head with a baseball bat and not feel anything. Now everything happens. And like Dan said, it's an ongoing thing. A lot of this stuff has gotten better, and it's gotten me, there's so much more care for people with head injuries now that you're able to deal with a lot of it. I know we talked about Dr. Comer before. It's kind of ironic when you go back. I nearly passed away in 2008. I became septic from playing through injuries. And for a couple of years, I just wasn't right. I was sleeping like 22 hours a day. I know I was on Lauber's table before games, like half asleep and not knowing what was going on, and lost 30 pounds and just chalked it all up to this, being septic and being on antibiotics for 6 months or whatever. And it wasn't until I went and saw Dr. Comer and got tested for a lot of things, and I got tested for everything. And he realized my hormones were like, I was not making any of my own. So I was able to go through protocol with him and go through therapy with him, and he truly, and that really did save my life, because at that time I was really bad off, and I did not know it was to do with head injuries. I thought it had to do with another illness, but everything you're showing on the screen was all me. I just didn't know it. So it's that education, and it's almost forced education, because bullheaded people like myself and Dan will play through it, or we'll ignore it until it comes to the point where you can't ignore it anymore. And that was ultimately me. I could ignore it because there was no effect on my play. There's no effect on my performance. So I wasn't jeopardizing my ability to work. I wasn't jeopardizing the team. And once that happened and the physical manifestation of the injuries happened, that's when I was forced to quit. Luckily, I was able to come through it, and nothing substantial happened while I was playing through these and didn't really realize it. So needless to say, with the MRI and the CAT scan and stuff, I was probably a ticking time bomb as it was. And who knows when the microhemorrhage was there. I don't recall those conversations, but I'm very thankful for panels like this, and caring physicians and caring physiotherapists and teams full of people that take care of athletes. And as a father now, I'm very aware of my daughter. She's had a few, and I'm very very overprotective of her skull, when I wasn't very protective of my own. But I'm happy to be here to help, and if anyone needs my contact info and wants to reach out further to talk about it a little bit more, I'm here to help. And for your athletes, your children, or yourself. And thanks again for having me.
Very, very impactful, John. James, we've been friends a long time, and watched you battle through that and struggle. And it's with great appreciation that we have you on here today, you as well as Dan. It helps for people to understand when we actually connect the athletes, as much as we can talk about protocols and everything else. But once we connect those athletes, it's phenomenal. And I know, Dan, you had an extra little piece that you wanted to add there.
Yeah, and what I'd say is, getting the opportunity to play with John and kind of growing up, he was one of my favorite players. I was a few years younger than him, and I think everybody in Peterborough idolized him. And then fortunate enough to play with him, just tough as nails. He'd be like getting work done on the table, as much as he possibly could, to make sure he kept himself together to go out. And man, did he play hard. And for a big guy that is really tough to defend, he put his body in the line every single game and every shift that he had out there. So it's pretty even hearing his story, I know all of it, but hearing it kind of for me, it brings up a lot of emotions on the value that we put on ourselves as athletes, and the importance of it. He mentioned about the testing that we would do. I don't remember doing I don't know if it was scat testing or the testing, the baseline testing that we would do before a season. I think the first one we did might have been the first year that I had a concussion, and John saying he would try to do worse than the early one. I didn't think of that. My baseline test in 2008, when I was out of it, I couldn't go on a computer without being sick. Had to be in a dark room for weeks. It was bad. But when I did my the test again and comparing it to my baseline, it was better in some ways. So I think that's the other thing, that it's not always is easy to see. I think the important thing is, again, probably what me and John, if we were more educated, would have possibly done, and hope, I like to think that I would have done, is making sure that you're removing yourself. So anything that you're going through with baseline testing, and the preventative measures, the education that we provide to our players and athletes, is really important to make sure that part is communicated very strongly to them, of like, hey, being tough is one thing, but being smart is even harder to do, because at times you don't want to be as honest, because it means you might not play. But not playing over a 1 week period sometimes is better than, or is always going to be better, but you know, it might end up being 3-month period instead of a week or two. So, you know, again, Junes, a lot of what you say there, it kind of brings up some other things that I wasn't myself, you weren't yourself. And you mentioned Eddie Camo on here, whether he's still on or not. He coached in Colorado, and just hindsight, looking back at when I played and when I was dealing with it, I wasn't myself. I wasn't normal. I wasn't, just my personality was much different. So I think you start to see that, and you're not aware of it at the time, but years later, you start to realize, wow, that was me, you know. And you're dealing with people in a way that, yeah, that they, you know, they're perceiving you from their experience with you, but you know, if you're dealing with it on a regular basis and trying to recover from it, you become a different person. And again, I think, Junes, that was the one thing that we were aware of at the time, and we wanted to try and do right by you and anybody that cares for somebody. You see that. But again, a couple things that kind of brought back up some thoughts that I wanted to share.
Appreciate that, Dan. And just for some of the trainers out there, someone that's 49 years old still knowing that it's elbow, apple, carpet, bubble, and something else. Memorizing words for that. I'm not a normal person by any means. I can't remember what I had for lunch, but I can remember trying to mesmerize whatever that is, the scat or whatever. So I think I probably got those words right, but I'll sign off now. Thanks, guys.
Well, it probably is the perfect segue into our next two presenters. So, gents, thanks for sharing your story. It's greatly appreciated. You know, anytime that we can show people there's actually a life after lacrosse, and you two are two people that are able to show that, you know, being GMs and coaches of teams and everything else. So thanks for that. So the next two presenters we have are very important. It's our next stage with Lacrosse Canada of trying to build ourselves a mental health program. And they'll be able to kind of correlate a little bit here on sport-related concussions and mental health, and be able to walk us through here. So our two presenters are Dr. Pam Weatherby and Dr. Carla Edwards. So Pam Weatherby was born and raised in Calgary. She competed in multiple sports, playing basketball at University of Calgary. She graduated medicine and completed her psychiatric residency at University of Calgary. Dr. Weatherby has special interest in working with athletes since her residency, is involved with Canadian international sports psychiatry groups, as well as Global Summit Group, aiming to grow the area of sports psychiatry around the world. And our second one, her partner in crime here is Dr. Carla Edwards. Carla provides consultation and support to high-performing athletes, both elite professional athletes that focus on diagnosis and treatment recommendations pertaining to struggles with mental illness. Performance enhancement strategies are interwoven into the overall approach to wellness. Special consideration is given to elements specific to the sport, and interpretation is challenged as well to the development of the treatment approach. Her services are extended to varsity athletes, national teams, and we're lucky that we're going to announce here a great partnership with the two of them to build out a mental health program for athletes, ranging all from the national teams all the way down to grassroots level. She has treated Olympians, athletes from Swimming Canada, Athletics Canada, Trican, Hockey Canada, Skate Canada, Cycling Canada, and she will be best known for her work of helping Lacrosse Canada in the future. So I will welcome the two of them.
Thanks so much, Terry. Did you want me to share my slides, or do you have our slides there loaded up? There we go. Perfect. Thanks, everyone. It's tough to go last. We were ready for this, though, and psychiatrists are used to being on the clock, so we will do our best. We've got 3 minutes. We might go a little bit over time. I want to thank Terry and Lacrosse Canada for inviting us to be part of this all-star lineup, and it's a tough act to follow, all these great clinicians and lots of experience and stories, so appreciate being part of the lineup here. Happy to present with Pam as well, and we'll walk you through a piece of the mental health puzzle. There's obviously mental health runs deep across concussion and other elements of sport, but we're going to show you a window today. Terry, you can get us started with the next slide. All right, so why are we here? I mean, we know that concussions can present with lots of physical symptoms, and obviously people on the sidelines need to be part of the initial assessment and the follow through. But, as Dr. Bauman said early on, the team needs to be quite inclusive and comprehensive, and we're happy to be part of that team. We are medical doctors who have special expertise with sports and athletes. So we go through medical school. So as a result, we can be covered by provincial health insurance. We can order blood tests. We can order diagnostic tests. We can make diagnoses. And then with that, we can do a lot of things. We can deliver psychotherapy. We can prescribe medications if needed. And we work very closely with other interdisciplinary team members to take care of the athletes. And if you think about that slide that Shannon put up a long time ago, where it brings you through the various stages of concussion, recognition and the acute stages and beyond. Not yet, Terry. We're sort of part of all of that. So think about us early, think about us often. We can work with you and work with the athletes to provide lots of support. There are a lot of different mental health practitioners and deliverers of various services who have various levels of expertise and provide lots of different services. We're just one of those, but again, I just want you to know what makes us a little bit different is that we are physicians. We can do lots of different things, and we can do the psychotherapy side. We'll get into the treatment in just a minute. But it is important to kind of get us involved early. Pam, over to you now.
Next slide. So we've talked a little bit about symptoms of concussion, and there's a lot of overlap when we think about mental illness at all as well. Symptoms tend to be pretty non-specific. They have to be subjectively experienced and reported by the athlete. So as an observer, we sometimes miss these things. It's not quite as obvious as a fracture or a sprain or a major laceration. The athlete typically has to tell us what's happening. And sometimes, like John and Dan said, they're pretty good at hiding it. So some of the common symptoms that we see after concussion might include depression, anxiety, difficulties with sleep. But some of the other symptoms that we will see that we don't talk about as much, but I think they did a great job talking about it just before this, is things like anger, irritability, fogginess, aggression, a lack of interest and joy in things that used to bring joy. Concussion in itself can actually also lead to symptoms of trauma-related disorders like PTSD, or can bring on thoughts of suicide, urges to harm self. Now, these can be due to the concussion itself, but it also could represent either the exacerbation of an underlying mental illness or the development of a brand new one. And that's why it's so important to have a mental health specialist involved. We know that in most cases, these emotional symptoms will resolve with the concussion, but depression, anxiety, some of these emotional symptoms can also prolong and complicate recovery. Next slide. There's also a number of psychological and social pieces that we think about as unique to athletes. So when someone suffers from a concussion, athletes can develop a fear of injury or a re-injury. There can also be a bit of hesitation, a fear of exacerbation of symptoms that can make people a little bit hesitant, that can impair performance, and it can impede in other areas of life. You also think about taking an athlete out of their sport environment, out of the school, out of work due to concussion, and they can lose some of their coping strategies, some of their outlets, some of their social support. And we talk about athletes being hard workers and committed and being really tough, but you take them out of this environment as generally the type A perfectionistic type people that we are, and that's going to create more difficulties. So we're going to take them out of that environment that's so familiar, and that can in itself create an increase in distress. Next slide. In both Dan and John talked about how important it is to build that education. It's so critical, but the other barrier that we want to think about is stigma. Dr. Edwards and I are very passionate about reducing stigma as it pertains to mental illness in athletes. There was actually information that was gathered by the IOC that showed that about 2/3 of elite athletes think that talking about mental health is taboo. So if we have 2/3 of athletes that aren't talking about it, we're missing a huge chunk of athletes that potentially need support. when athletes do speak up, it's important to note that the evidence would show that they're going to open up to their peers, to their family, and typically to coaches. So we want to ensure that people feel prepared and feel like they can listen and encourage these athletes to reach out to coaches or to reach out to the professionals that they might need, whether it's a mental health professional or their team physician. We really want to improve the ability to access to mental health supports for these athletes. Next slide.
All right, over to treatment options. As has been said by a number of folks tonight, treatment options need to be individualized. Terry, if you hit enter, I think my little toolbox might open there and some fellow might pop out with some, oh, there we go. Oh no, go back one slide. It's hard when you don't control your own slides. Let's see if we can get the guy to pop out. There we go. We need to individualize treatment, right? So, we've heard some stories tonight about, the wide variety of different treatment options that are available, and different ones work for different people based on what their symptom clusters are, which we heard about earlier. So it's really important to listen and hear and include as many folks as we can to really try to narrow down what the person needs. So from our point of view, when we get involved, we look at the full gamut of what folks might need. Some people assume that psychiatrists are all about medications. We don't just prescribe medications. And I have to say, in my practice, where I see athletes 100% of the time, maybe 15, maybe 20% actually take medications for a variety of different things. So we do mostly other things. And one thing we do really well is listen and try to help educate, just like all of you folks here tonight, and really work on lifestyle management. We know that concussion management all the way through and recovery and return to sport really depends on ongoing behavioral management and listening to your body. So sleep schedule is huge. Nutrition, hydration, stress reduction, right? And stress reduction then flows into the next piece, which is psychotherapy or talk therapy, counseling therapy, like whatever you want to call it. It could be just a chat with some of us. So there are some specific therapy modules like cognitive behavior therapy, where we look at events that trigger certain thoughts or certain feelings, and then result in either anger, sadness, anxiety, whatever it may be. We can work on specific things like that. There's various mindfulness-based stress reduction. There's yoga, there's meditation. There are so many different modalities that we can tap into that we use on a regular basis. And then pharmacotherapy if needed. So very, very symptom targeted. If a person has, anxiety or depression, we'll look at the context. It's normal for an athlete to be anxious or depressed if they're not able to train or compete. We understand that. We're not going to throw everybody on a medication because they feel that way, but we look at the context, we look at the timeline. If something goes long enough and it spills over into daily impairment or function, then we may need to have a conversation about medications, but it's certainly not something that we jump to. Sleep promotion is also important. Again, we work on sleep schedules, we work on sleep hygiene. If that doesn't work, and if sleep problems are tied in with other things, we know that concussion recovery is very dependent on enough sleep. So sometimes we do need to target that and treat that if necessary. Okay, but again, it's very much individualized. Go ahead, Pam.
Yeah, so we are doing a bit of like a quick breakdown, but it's so much bigger than this. And if we were just have you take anything away from this, is that mental health symptoms are actually very common after sport-related concussion. And that if we can recognize and treat these mental health symptoms early on, we can actually help not prolong or complicate the recovery. And finally, that we want to connect athletes with the appropriate mental health professionals as early as possible when these symptoms start to manifest. Because now that we can educate and we are available, we want to make sure that we are involved in the team as well. So thank you very much for having us. Thanks for your time and listening until the very end. We'll turn things back over to Terry, but we do have our emails available in case anybody has any questions later on.
Before you two go too far, I know the difference, but maybe you can explain the difference just from a practitioner standpoint, the difference between psychiatry and psychology and how that's covered medically, and the possibility of where can we find professionals like yourself across Canada.
It's a great question. It's a commonly asked question. I think the most common mental health providers in Canada that we have are social workers, psychologists, and psychiatrists. Psychiatrists are the only ones who are medical physicians and therefore are covered by provincial health care. And we require a referral from another physician to access our care, whether it's a family physician or a sport medicine physician or somebody else. Psychologists, social workers are not medical doctors, so they typically are paid for by benefits or out of pocket. And different insurance companies will cover different practitioners, so you would need to check on those elements. But the biggest difference, I think, between psychiatrists and the other categories is that you know, we can prescribe and provide psychotherapy and do diagnostic tests and laboratory investigations. Those other folks can't. The other folks mostly work through psychotherapy, life skills advancement, other types of coping skills, which are all very, very important. And again, another piece of the puzzle. We just kind of can add an extra element to those wedges. And we have, again, the benefit that we are of no cost to the organization or to the athletes themselves.
Thank you. And I know I've had some of these conversations with the practitioners on this call, and it's kind of looking as how we've progressed over the years. Is, you know, as athletes, we used to look at, you know, you just show up and you would just physically go on the floor and train, and then we, you know, we finally gotten to the point where, you know, we would do some dry land training, and now, you know, then when nutrition finally started to come around, and, you know, athletes started to put nutrition together, and now we're finally getting to the stage of understanding on how the brain works, and how important the brain is with regards to, you know, concussions and mental health. And, you know, that might be the final piece, and how beneficial things like this can become to our athletes. So thank you so much for everybody that was involved in this. You know, this took us probably about 6 weeks to try to get everybody together and on the same page. And we look forward to doing many more of these across Canada, and maybe breaking down these in further detail, but and basically pulling everybody into their forte. We would respect anybody that was on this call that's please give us any feedback. I will definitely put my email in the chat here if you would like to be able to send your comments along. I know Wendy will send out a bit of a Q&A afterwards here to all members, and so they can basically collect their PD points. Thanks, Carla. I see that you've put your email in there. Pam, are you able to maybe just to dump yours in there as well? You know what, if everybody as part of the therapy group here, practitioner group, if you're comfortable, we'll send it to the participants that were on there. Is everybody okay with that? So before we close here, does anybody have any questions that they would like to put forward before we end? All right, well, thanks to everybody for their time on a Sunday night. And unfortunately, those that are Bills fans like myself, we are losing, but you can grab the fourth quarter. Take care, be well, and be safe.
Thanks, Terry. Thanks, everyone.
Thanks, Shannon. We appreciate your time.
Great, Terry.
Thanks, guys. Appreciate everything.
Thank you. Have a good
job,
night,
Olga.
everyone.
Take care.
Bye.